For today's video, Dr. Robert Mathis, or as I like to call him, Dr. Bob, is back with us again to answer your questions on hormones and hormone replacement therapy. It's really great to have you back, Dr. Bob.
Hi.
Thank you for coming back. I think before we get into the questions, Dr. Bob, we have to say really briefly that this video is for entertainment purposes only. We're not making any medical diagnoses, nor are we recommending any medical treatment.
Right.
I have 2 pages of questions here from my audience, so let's get right into it.
Okay.
I kind of grouped it into categories so that I can put timestamps down below in case people just want to jump ahead. So maybe we'll start with testing, because I got quite a few questions on that. First of all, if somebody is on hormone replacement therapy, I think something else that's important to say is that we are always talking about bioidentical hormone replacement therapy when we're talking to you.
Right.
So if somebody is on bioidentical hormone replacement therapy, what should they be testing? And should they be testing regularly as far as blood testing?
So the answer is yes, you want to test all the hormones. You want to test testosterone free in total, because the free testosterone is the important number. You want to test estradiol, not estrogens. You want to test estradiol. Estrogens is all the estrogens, and you want to look at estradiol only. Number 3, you want to do progesterone. The testosterone will probably include an SHBG if you can get one, or if it's not too expensive. That's helpful. And that would be it just for the hormones. And number 2, what I would do is, of course, I always like to check free T3 by tracer dialysis and reverse T3 to see what the thyroid's doing. Make sure they have adequate thyroid function to help metabolize the hormones.
Are you suggesting anything else that could possibly be affected by hormone replacement therapy?
If they're going to go on a rhythmic method where they're going to have a cycle every month, we need to look at their ferritin level. And we need to look at the iron with TIBC and look at their total iron and iron binding capacity. Make sure they have enough iron to be able to have a cycle. Okay. And I would check the blood count of CBC, make sure they have enough blood so they can afford to lose a little bit. I mean, we can go on with testing. I mean, I look at A1Cs, I look at chem panels. Homocysteine is a very important molecule because it leads to glutathione, which leads to anti-inflammatory. So I want to make sure the homocysteine is somewhere between 7 and 9 and not above that, because I want to make sure they're making an adequate amount of glutathione so they can detox the estrogen and they can detox other chemicals and so forth and keep themselves away from inflammation as much as possible. So we could spend a day on testing, but one of the questions that I saw was a Dutch test. And the Dutch test, very expensive test. There's probably a better way to do this, but I'd like to start looking at the submetabolites of the estrogen, which would include 2, 4, and 16 hydroxy estrone, and then also look at their submetabolites, which are a product of methylation. So it might be worthwhile to check the MTHFR and see how that's doing. If they have a defect or a variant there that would slow down their ability to methylate their hormone metabolites, and that can become a problem, not for many people, but for some. So you want to make sure the methylation's okay, and if not, if that's treatable. I'm also now looking into CharaOmni to see how that affects the emotional quality of one's life. So I'd like to look at those 2 genes. And there's a test at Life Extension, which is a buccal test from the mucous membrane. You can look at those genes. It's $129. It's great. So now you can really look at CharaOmni and MTHFR and see where a person is. And if somebody's an emotional train wreck, then we can understand that they probably have a slow CharaOmni compared to the people that are kind of like lazy, so to speak. Those are the people that have fast CharaOmnis. I'm starting to get into that detail of the hormones and the genetics.
I took a similar test. You had me take that gene test years ago.
Right.
And knowing some of those genes like CharaOmni, it made so much sense. I could finally understand myself better, because they really play into your personality, and to, like you just said, it's quite important. So
now you know why you're screaming at the husband.
or
not screaming at him.
Yep, that is true. Okay, but if somebody, obviously testing can be expensive. If somebody just needs to test the basics, then just the sex hormones and possibly thyroid.
If you go to lifeextension.com and you select the female basic hormone panel, that's $75 for 5 hormones. a good half of the time it's on sale for $56. So now you're looking at $10 a hormone. It doesn't get any cheaper than that. I send a lot of women to Life Extension. There's about 5 other labs. I have an online lab list, which I can send to you and you can just forward to people. There's a number of online labs where you don't need a physician to order the test. You can order your own testing. And so this is really a lot less expensive. I mean, it's instead of $2,000, it's $200.
And how frequent, if somebody is on HRT, how frequent would you suggest testing?
The first few months, it's a little tough because I got to make sure the levels are proper. So sometimes, depending on the person, I have to test a little more often, which can be kind of pricey. So we're looking at 2 or 3 times in that first 2 or 3 months just to make sure that the numbers are getting there. Anytime there's a suspicion that they don't feel well, I like to look at the numbers. So that would be number 2. Anytime I just to look and see. And then in general, once the numbers are good, you can probably do it twice a year, once a year, twice a year. And that's probably all you need.
You were just talking about estrogen metabolism. I had a question on estrone. Why estrone is higher in menopausal women than estradiol?
I'm not sure that statement is completely correct because most of the people I see, their estrone is about 30% of their estradiol or 50% of it, maybe. I do have a few women that the particular enzyme between estradiol and estrone is faster than it should be. And those people process estradiol into estrone rather quickly. One person, for example, recently, her estradiol was 136, but her estrone was 680. She's really pushing it into estrone. So you got to put a lot more estrogen on her to get it to stay in estradiol. It doesn't even stay. It just goes over to estrone. So Dr. Wright up in Seattle at the Tacoma Clinic, he on his own discovered that the cobalt drops can slow that 17 beta hydroxylase enzyme, can slow that enzyme down so that the person will keep their estradiol in the form of estradiol. So I have a couple of people that are trying the drops as per his discovery, and one person that seems to be helping, and the other person I'm not sure yet, but that's kind of what I do when I see too much. On rare occasion, I see too much estrone. They're always at least equal or estrone is half of the estradiol. And when it's the other way, then we know that that enzyme's going way too fast.
Okay. So I have 2 questions for you on that. Those cobalt drops, they are prescription or can anybody get them? Or
you can get them at Amazon.
Okay.
No problem. And then it's like 1 to 3 drops of cobalt per day. And that's about it.
And then why is it a problem if estrone is too high? Tell us just really briefly.
Okay, so we talked about how estradiol, and it'd be nice if I had a chart and I could show you how it works, but estradiol breaks down into estrone, which then breaks down into 2-hydroxy, 4-hydroxy, and 16-hydroxy estrone, 3 submetabolites. When you take DIM, you increase the 2-hydroxy component of that, and that helps run some estrogen off of the body. So some people have to be careful with DIM because it can lower the estrogen too much. So just keep that in mind. And then the 4-hydroxy, some people are concerned about 4-hydroxy converting into a submetabolite that's not very friendly and can produce inflammation. And that inflammation is what is a problem. So we don't want an excessive amount of estrone, which means we have an excess amount of that 4-hydroxy converting into this not so friendly submetabolite, which produces inflammation. This is kind of what happens with people that aren't methylating very well, which is why we need to kind of check that methylation. It's really the inflammation which is a problem in terms of keeping the cells healthy, because the unhealthy cells are really the ones that are inflamed the most. And if the cell gets into this cell danger response place, then the cell can lose control of itself. And then that's when we have, and I don't want to say the big word, but the answer is cells can lose control. And if they lose control, then there's only one choice left, is they have to be taken out. And that's where, if you're on a rhythm method, the P53 can help with cleaning up and eliminating those unhealthy cells. And then progesterone is a apoptosis hormone. So once you get into the progesterone phase, that produces apoptosis or cell death. So there are ways to clean that up, but the most important one is to not be inflamed. And that's why the glutathione, resveratrol, quercetin, some of these supplements are really helpful to keep the body from being too inflamed. Not to mention sleep. Oh, what's that? Oh, yeah, sleep. Oh, yeah, you're in menopause and you don't sleep? You got to fix that, because that's right directly into inflammation. That's not a good thing. So sleep, comfortable relationship. You can't have somebody yelling at you because that produces inflammation. I mean, you got to work on those other lifestyle parts, a little light exercise.
Now, you didn't want to mention the C word, but I did have some questions on that. And you and I have talked about this a bunch, and I will link all of those videos down below. But one question was estrogen positive cancer. Why do they call it that if estrogen is not to blame for it?
The breast tissue, the vaginal tissue, and a number of other tissues in the female body and even in the male body have estrogen reception. They have receptors so they can receive estradiol, and they respond to estradiol. So when a cancer is called estrogen positive, that's actually a better type of cancer than the ones that are estrogen negative. The cancers that have no receptor response, those are very poorly differentiated, kind of really out of control cells, and they don't even have receptors, and they're very hard to deal with. So you're better off with a positive response because then if you lower the estradiol, you lower the growth. And if you raise the estradiol, you can raise the growth. So the story goes, I've had a couple women who started their hormones, and there was something in the breast we didn't know about, which how are you going to know? I mean, you can do a mammo and you might not see anything, or you don't see anything. So you start the hormones and all of a sudden there's a little lump pops up. So the estrogen caused whatever was growing anyway to speed up its growth and make itself visible like 5 or 7 years earlier than it would have been. So I believe the estrogen saved their life because this thing showed up right away, which it wouldn't have if they wouldn't have started HRT. Dr. Taguchi, who does oncology here in Santa Barbara, she's had many, many patients who have their breast surgeries for a cancer or lumps. And the ones who started the hormones after the surgery, she's finding they have fewer recurrences than the women who don't go back on hormones after the surgery. So the thing is, we just want to make sure the metabolism works. We want to make sure methylation works. We want to make sure that you have some modest supplementation going on so you have enough nutrition to make everything work better, and make sure lifestyle is comfortable and sleeping and not so burned out you can't get your rest, because all those things lead to inflammation, and inflammation is the bad guy, not the hormones. Because if hormones cause cancer, pregnant women estradiol levels are 3,000 plus. Mm-hmm. Progesterone is like 50 to 75 or even higher. And if hormones cause cancer, all pregnant women would die.
Yeah.
Mother Nature
would have much more occurrence of it when we're younger too, when our hormones are high. But usually, in rare cases, it can happen when you're younger. But usually these cases happen when we're older, when hormones are
which means they're inflamed. And if there's no progesterone around to protect them, and I have a lot of physicians who say, oh, no, you don't need progesterone. You had a hysterectomy, you're okay. And I say, well, what about the breast tissue? Oh, is that female tissue? Yes, it is. And there's 2 of them. And they cycle histologically through 4 distinct cycles throughout the month. So they need protection as well. So yes, you need progesterone.
Okay. You actually already answered the next question, which was women with a history of cancer, estrogen positive cancer, should they go on HRT? But you just said your colleague actually sees a lesser occurrence. So
her study of about 150, 170 women so far over probably 7 or 8 years. It's been a little while since I've talked to her because she keeps adding people on the study. And that's her conclusion, is that people do better on hormones. And the study that was done, a Women's Health Initiative that was done in 2001, I think it was, with 50,000 women, that study had the same results. In other words, the synthetic estradiol and the synthetic progestins, there were more cancers in that group compared to control group. And then the synthetic estradiol by itself, no progesterone, synthetic estradiol by itself had fewer cancers than the control group. So they didn't report that part. They only reported the increase in cancer, which was, now it's been associated with the progestins. What are progestins? I have to talk this way because progesterone is different than progestins. Okay. Synthetic progesterone is a progestin, and synthetic progestins do not metabolize, are not very friendly. And unfortunately, the birth control pill that's what it is. It's synthetic progestins and synthetic estradiol. But there's thousands of women who've had the birth control. I have a woman the other day. She's been on the pill from age 20 until 45. She's fine. There's no cancer. There's no problem. She's fine. Lots of people are fine. It's just that little subgroup of people that have genetic aberrations and they don't quite metabolize things the way they should, or they get lifestyle things going on, produce a lot of inflammation. They're the ones that get in trouble. It's not the big group. It's the few little people. Just to make it clear.
Now, since we're talking about estrogen, I talked to another doctor the other day who told me the way they treat females in menopause is with oral estrogen. And they, for two reasons. He told me, first of all, they don't believe that you can get the estrogen numbers high enough on topical estrogen. However, when he looked at my numbers, he was shocked that they were quite high. He said he had never seen that with topical estrogen.
Right.
Secondly, he said that it was the only way to increase esterified fatty acids, which then help with the protection of stroke and heart disease. How do you feel about that?
Wait a minute, the only way to increase esterified?
Yes, esterified fatty acids, which he feels is important to protect from heart disease and stroke. Okay. Now, I know that you are not a fan of oral estrogen.
It's not if I'm a fan or not a fan. It's the science. Yeah. When you look at the science, you say to yourself, what happens if they swallow the estradiol? I mean, there was one point we did a study with one of the compounding laboratories here. We did a study with oral estrogen in oil drops and progesterone oil drops and so forth, because we're looking for another method of entry. And the answer is, oh my God, the estrone levels were 1,000, 1,200, while estradiol was, 75 or 100. And just the other day, I had a person, like I said, she was 136 and her estrone is 680. I mean, you can't do oral hormones. Right? It's not estradiol because progesterone is different. It has different metabolites. It's not a problem. And some people do better with progesterone orally than they do with creams. But estradiol, you're going to produce a lot of estrone. As long as you know what you're doing, it's up to you, but I wouldn't do it.
I personally have, before I met you, I was on oral estrogen and I didn't get my numbers of estrogen above 40. Now they're 10 times as high with topical estrogen.
Yep.
So definitely topical estrogen does work. Yeah. But I had never heard this whole thing about the esterified fatty acids and that was the only way to actually make sure that they're being produced. So I wanted to get your take on that.
I'd have to look that particular pathway up and double check on it, but the reasoning isn't working for me because you're going to produce a lot of estrone. And then you have 2-hydroxy, 4-hydroxy, 16-hydroxy. They all have to be broken down, metabolized, and pushed out the back door. And with the estrone at 600 or 1,000, that's a lot of work. And it takes a lot of metabolites. It takes a lot of resources, called resources, which means vitamins, minerals, B6, B12, all these different things to do all this, and that's a lot of work for the body.
It can be so frustrating for us women because there are so many conflicting opinions out there.
I would recommend that a person listen to as many of the different opinions as she can and then decide, just which one do you want to follow, because it gets tough. I mean, I have people come in right now I have a lot of people doing testosterone shots, and there are numbers like this one person, her testosterone is 525.
Free testosterone?
No, her total testosterone.
Okay.
Oh, her free testosterone is like 35, and the range is 0 to 5, and she's 35. She's 7 times normal on her free testosterone. So she has plenty of drive. In fact, I'm surprised her husband's still alive. So
well, you got me right to the other questions I got, which are on testosterone. I got quite a few questions on testosterone. First of all, how important do you feel testosterone supplementation is for females?
Testosterone is good for muscle. Testosterone is good for metabolism to help weight loss. And testosterone is good for that psyche because it helps you be a little more aggressive in life and kind of get out there and do what you want to do. So I'm good with testosterone as long as the ratios are right. You know, Jonathan Wright, who we talked about earlier, who came up with the cobalt drops, he wrote me a letter once and he said, just follow nature. So I like to stick with Mother Nature. She has been doing this for 1,000,000 or more years. So I'm going to yield to her wisdom about what we should be doing.
That makes sense. I would imagine that testosterone for females is also important for libido.
Some people don't need any. Some people need estradiol, and a lot of women do better with testosterone for the libido. So yes, I'm sorry I left that off, but that's correct. That'll help them. Yep. All of a sudden, the husband looks good again.
Now, you mentioned it sounded like you're not a fan of shots. What do you think is the best delivery for testosterone for females?
This is a tough one because really there's only testosterone cream that's compounded. Makes the most sense because of the concentrations that I can produce, that I can ask for. If you go to shots, I don't know of any compounding lab that is making low concentration testosterone injections for women. I don't know of anybody right now. I'd be happy to know about that. I could probably ask for it, but a lot of women aren't very keen on taking shots. And that would be like a shot every day because I don't want to do this. I don't want to give them a shot and then have it go like this and then go back up. And I'd rather just have kind of this kind of thing going on. Number 2 is the gel. So there's the male gel, which you can take a little pinch of gel out of the package and rub it on the forearm. So we got the cream, we got the gel. It's very hard to do the shots because you want to give them you're going to give them just the tiniest amount of the male testosterone if you're going to do that.
How do you feel about pellets?
I'm not a pellet guy. First of all, there's no adjusting. I'm actually waiting for 2 patients right now for their numbers to come down. I mean, one, her testosterone is in the 500 range, and another person's is in the 250 range, and we've been waiting for like 3 months already. Because how do I can give her hormones, but I'm kind of waiting for the testosterone to come down because it takes 3 to 6 months or more for those numbers to come down with the pellet. You got to put it under the skin, risk of infection, risk of bleeding, no adjustments, and expensive. Most people don't have that kind of income.
So compounded is your favorite compounded cream?
Well, that's really all there is.
Now, sticking with testosterone, one question was about testosterone in men. What's the relationship between testosterone and prostate cancer, testosterone and stroke, testosterone and heart disease in men?
Okay. So again, it's my personal belief, and what I've seen in medicine is that it's not the hormone that causes the cancer. It's the inflammatory processes that disrupt the cell's normal function. The cell slips over into an uncontrolled form, mostly from this extreme inflammation, chemicals, toxins, mold toxins. I mean, there's all kinds of other reasons for inflammation to be there. And the prostate is just like everywhere else. You know, it's a very closed organ. It's very hard to get blood in and out. And prostate infections are common, even though they're not diagnosed. Low-grade chronic prostate infections are probably the source of prostate cancer, probably. And there may be a few genetic problems in there, such as the methylation or COMT that might have something to do, and some other genes that have something to do with collective inflammatory processes. There's also inflammatory genes that get turned on in some people, according to the genetics I've studied. And so they're kind of at a higher risk because they have more inflammation in general than they should have. So what does the testosterone do? It doesn't cause the cancer. It will provide growth for it, but it will not cause it. And again, if you have a testosterone receptor positive, those kind of cells are more able to be controlled. The cells that don't have hormone receptors, those are very poorly differentiated. They grow wildly, and they're tough to deal with.
And as you mentioned earlier with breast cancer, same with men, usually prostate cancer happens late in life when testosterone is barely existing.
Yeah, some people argue that it's the low testosterone that allows the prostate to get so inflamed. And it's because the prostate lives on DHT, which is the hormone right after testosterone. So as testosterone breaks down into DHT, and when the testosterone is low, there's very little DHT to provide for the prostate. And so maybe that's the reason why the prostate gets kind of overwhelmed.
I'm assuming we just talked about prostate cancer. I'm assuming the answer is the same for stroke and heart disease, that they are caused by inflammation, not by testosterone.
They're not caused by testosterone. In fact, there was talk about 15 years ago of developing a protocol for men that came in the ER that had a heart attack. They were going to give them IV testosterone to help slow down or stop the heart attack. I don't know where we are on that one, but the answer is, again, if you do a coronary calcium score on a person, which is a screening tool, and it looks for calcium buildup in the heart on men or women, anything above 100, 200 in women is considered significant. Anything above 400 in men is considered significant. That calcium score is a real telltale of what's kind of going on as far as coronary vascular disease and so forth.
What about supplements, or we should call them hormones probably because they are hormones, such as Pregnenolone and DHEA? Will the body transform them into other hormones if needed? Let's say I'm low in estrogen and I start taking DHEA or Pregnenolone. Will the body take that hormone and turn it into estrogen, or what happens?
The conversion rate is pretty low. One time I had a woman come in, late 70s, and I checked her and her estrogen was like 150 or something. And I went, "Are you on hormones?" She said, "No." I said, "What are you doing?" She said, "Oh, I take 500 of DHEA every day." I went, 500? Who told you to take that? Oh, that's just some company just produced it at 500 milligrams a day. Oh my God, you're taking the female dose is 5 to 10 milligrams, maybe 25 tops, and she's on 500. Okay, yeah, it runs off into estrone and testosterone, and yeah, but the dose, look at the dose, and look at her estrone level. It's going to be through the roof. What does that mean? That means she has to metabolize all those hormones. She's got to have all those resources at her age and at her nutrition level to be able to process all those things out of the body. I don't recommend taking DHEA at 500. Some people get real crazy on that much too. So at the doses that it's recommended, no, it's not going to produce changes in the corresponding hormones, although DHEA can turn into estrone pretty easily.
But at the doses recommended, we don't have to worry about it.
I don't think it's going to do much. And I'm not a big fan because I don't want any more estrone around than I have to have, just because it requires processing.
Now, would somebody apply DHEA topically? Is there still the risk of it turning into estrone, or is it just taken orally?
It's going to be less conversion if you take it topically, and some people do it vaginally to help enhance the vaginal lining. I haven't gotten into it very much because I'm not a big fan, and there's people out there that are crazy about it, so probably have to talk to them. I haven't seen anything that makes me want to go there yet.
Okay. Same with Pregnenolone? You feel the same?
Because estradiol will take care of the vaginal area because it will bathe the whole body in the proper amount of estradiol, which is fine. Somewhere anywhere from 85 to 100 and up to 200 on the estradiol is fine, somewhere in that area. And Pregnenolone is a pre-hormone. So that's a pre-hormone for all the other hormones. One thing you want to say about Pregnenolone is if you take a statin drug, you are going to stop your production of all your hormones and your CoQ10. So just be careful with statin drugs because they'll lower your testosterone. They'll lower all the hormones. So it's not a good thing.
I thought it was Pregnenolone. Pregnenolone is a pre-hormone.
Cholesterol here, Pregnenolone, progesterone, 17-hydroxyprogesterone, over into DHEA and so forth. So the answer is, yeah, it's a pre-hormone. And it's the one that kind of seems to have a lot to do with brain function. So okay. I'm okay with Pregnenolone. Anywhere from 25 to 50 milligrams.
I have a few more questions for you. When we are on bioidentical hormone replacement therapy, do we have to worry about blood clots?
First of all, you have to understand what is a blood clot and why is it there? What causes a blood clot? If you have damage to a vessel, then the answer is you're going to release chemical factors that produce a blood clot, which is so-called inflammatory response. Are we back talking about inflammation again? Just fall down. And now you're going to get a blood clot somewhere because otherwise you're going to bleed. And that's just normal. And I look at D-dimers. What's a D-dimer? D-dimer measures fibrin split products, in other words, breaking down of blood clots. So I've been looking at D-dimer for a while, trying to figure out what am I seeing when I'm looking at this test. It's not a diagnostic test. It's usually used to look for pulmonary emboli. But I've been looking at it, and I'm saying probably at least half the people have a slightly elevated, not markedly elevated, but slightly elevated D-dimer, implying that they're breaking down blood clots kind of on a regular basis. If you don't have a coagulopathy, which some people do, and you never find out about it. I mean, I've had 37-year-old person come in and she had a stroke. Well, that's not normal. And that's not hormones. That's a hidden coagulopathy that nobody would have noticed unless you had to order the test when she was 20. Why would you order a coagulopathy screening for somebody like that? The answer is you wouldn't. And generally speaking, I don't see hormones as a reason for, except for synthetic progestins. Those are not such good things.
The last question I have for you is women who are on rhythmic hormone replacement therapy, such as myself, and I think we should explain really fast for new people what that means. So that means we are replacing our hormones sort of like Mother Nature intended it. We're taking estrogen in varying doses throughout the months. Same with progesterone and a little bit of testosterone. Through that, we get a period. So the question is, could we possibly get pregnant since we have regular periods?
So you have to ask yourself, is the egg basket available? And the answer is, the reason you went into menopause is because you're not harvesting eggs anymore from the ovaries. When the luteinizing hormone comes from the brain, goes down and says, ovary, give me 5 or 6 eggs this month that I can make available for pregnancy. And the FSH level will rise up a little. FSH, which is the typical menopausal hormone that they look at, and they'll say, well, your FSH is 130 or 120, you're in menopause. If it's 80, you're kind of on the fence, but if it's over 100, you're in menopause. So that means that the ovary can't deliver the goods. It can't deliver the estrogen, which means it can't produce eggs, which will mature on day 12 of the cycle. And as they mature, their estrogen level goes up, and then that will turn off the FSH feedback system and keeps it around 10, 5 to 15, 20 maybe for FSH. When you get in menopause, the FSH goes up to over 100 because the FSH stimulates the ovaries. The ovaries do not send a message back to the brain because there's no eggs to harvest. So the answer to the pregnancy is it's not going to happen because the egg basket is already out of viable eggs.
So it's not so much the FSH, because I just had my FSH tested and it was very low because I have hormones.
It's around 7 or 8.
Yeah, so it's not so much the FSH, it's just that the egg basket is empty, like you said.
The egg basket is not available, and when you stimulate the ovaries, they don't produce eggs, which then will mature and produce the estrogen to give you the peak on day 12. So we're simulating that peak, and by simulating that peak, we're following nature's advice as far as how things work. And Mother Nature goes, okay, I know what this is, because it's a known pattern. Somebody said, oh, I went through menopause, I'm done with that. I said, no, you're still in it. You just got past this hot sweats, the hot flashes and the sweats and not sleeping, and you're a little better now, but you still are in menopause. She says, really? I said, yeah. You're by definition, your FSH is here and your estrogens are here, and you're in menopause. Once you're there, unless you take hormones to go back out of it.
Now, I said that was my last question, but you just brought something up that I've always been curious about.
Okay.
Why is that? Why do women get hot flashes and all the symptoms of menopause, and then suddenly they stop, even though they are not taking hormones and they, like you said, are still in menopause? What makes those symptoms suddenly stop?
Because the system fatigues after 6, 8, 10 months, whatever it is, it'll fatigue, and then it can't respond. And that's probably what happens to hot flashes. You just burn them out until they're gone. And your body just doesn't do it anymore.
So even though we look at that as a positive, it's not necessarily a positive. It means the body is basically just too weak.
You're still in menopause. You still have no hormones. You still are at risk of the inflammation that's caused by not having estradiol around. The vascular tree, the heart, the brain. I have a patient right now. She's 32 years old. Her hormones are gone. She's 32. Why are they gone? She had her thyroid taken out 10 years ago. Thyroid gone, thyroid cancer. The doctors gave her T4. They didn't give her any T3. They only gave her T4. She doesn't convert D4 into T3. About 50-60% of people don't. She doesn't convert it. So she's had no T3 now for 10 or 12 years. She has severe cardiomyopathy because there's no T3. She has an enlarged heart because there's no T3. She has cardiac arrhythmias. She was dying. And she got a hold of me, and I gave her some T3, and I gave her the hormones. I gave her the rhythmic she's 32. I gave her the rhythmic program. She needs to have periods. She needs to have the hormones do their thing. And it's been a year, and she's 100% better than she was when we started.
Yeah.
There's an interplay between the whole system, and thyroid is important. The speed at which metabolism goes is determined by thyroid, which determines the temperature of the body, which determines how fast the enzymes will clear things and so forth. So, 1 degree centigrade doubles the speed of the enzymes. All the little pieces need to work. So you just have to make sure that they're all
working. Easier said than done.
It can be tough.
Dr. Mathis, I so appreciate you taking the time and answering these questions and helping as many women as you can.